Hi, everybody. This is Laura Young from the Department of Psychiatry at UT Tyler Health Science Center. I'm glad you're here today to join us for our session, Why Improving Access to Mental Health Care is an Ethical Imperative. We have Dr. Jamin Blood and Dr. Diana Robinson who will be facilitating this session for you. And let's go ahead and get started. I did want to let you know this is being recorded, and the plan is to have this loaded onto our SharePoint, excuse me, not to our SharePoint, but our YouTube page later today, as long as there are no technical difficulties. So Dr. Jamin Blood is a native of rural East Texas. He started his college education at Tyler Junior College and then transferred to the University of Texas at Tyler, where he completed his undergraduate degree from Louisiana State University in Shreveport. He attended Kansas City University of Medicine, where he received his Doctor of Osteopathic Medicine. After completing medical school, he returned to Texas to do his residency at the University of Texas Health Science Center in San Antonio and completed his fellowship in child and adolescent psychiatry at the University of Texas Southwestern Medical Center in Dallas, UT Southwestern, where he was the chief fellow. He is currently board certified by the American Board of Psychiatry and Neurology and Psychiatry. He came to UT Health East Texas in 2020 and became an assistant professor of medicine for the Department of Psychiatry and Behavioral Medicine and began working with us here in the fall of 2020 with the CPN program. His specialty interests include treating children, adolescents, and young adults with various psychiatric illnesses, also treating very young children and those with special needs. When not working with patients, Dr. Blood enjoys woodworking, gardening, serving in his church, riding dirt bikes, and all kinds of sports, especially basketball. And then I have here Dr. Diana Robinson. She is an assistant professor of psychiatry at UT Southwestern Medical Center. There is a correlation here, yes. She has a passion for providing psychiatric care to acutely medically ill patients. Dr. Robinson graduated from medical school at Texas A&M College of Medicine and performed her adult psychiatry residency at the University of Virginia. She completed her fellowship in consultation liaison psychiatry at Harvard's Brigham and Women's Hospital with a particular focus on cardiac transplantation, psychiatry, oncology, and infectious disease. Since 2019, she has worked at the UT Southwestern inpatient consult team with residents and medical students, and she provides psychiatric care in the co-located oncology clinic. In addition to direct patient care, Dr. Robinson is dedicated to improving psychiatric care through engagement with the regional and national psychiatry organizations. She currently serves on the Medical Education and Lifelong Learning Committee for the American Psychiatry Association. And since 2017, she has served as a member of the annual meeting subcommittee for the Academy of Consultation Liaison Psychiatry. From 2016 to 2018, she served on the APA's Clinical Liaison Council and the ACLP Evidence-Based Medicine and Guidelines Subcommittee. Her research interests include neuropsychiatry, global mental health, and psychiatry trainee education. And Dr. Robinson is an author of over 30 book chapters and peer-reviewed articles. You have a dream team here today who will be providing your education. And so I'm going to turn this over now to Dr. Blood, and I will pull up that PowerPoint here in 1 second, Dr. Blood.
All right. If you can't see the slides, please let us know in the chat. All right, so let me change my screen settings so I can see everything. All right, so today we're going to be talking about improving access to mental health care and how that's an ethical imperative. This is an ethics presentation, so we'll dig into, like what is, that ethical aspect about improving mental health care and how the best things that we can do for the children, the families of those we serve. All right. So this course is brought to you by the Texas Child Mental Health Care Consortium, and neither one of us have any conflicts to disclose. All right, so the learning objectives um, for today are, so by the end of this presentation, you'll have more knowledge in the rates of occurrence of common mental health disorders in youth and peripartum. Um, We'll summarize some of the negative outcomes and ethical concerns that result when youth and pre and postpartum women are unable to access mental health care. And we'll identify some favorable outcomes that may result for youth and women pre and postpartum when their primary care physicians engage in collaborative care models with mental health experts. All right, and so our goals are, so we're going to discuss the incidence of these mental health disorders. We're going to talk about outcomes for untreated mental health disorders. We'll describe some of the how these access programs work with their how the use of these ethical or the use of these programs is an ethical way to help you treat your patients through beneficence, non-malfeasance, and justice. We're going to describe Texas's CPAN and PeriPAN access programs, and we're going to discuss some barriers to treatment in your clinical settings and how we can identify those, and then we'll help develop plans to help utilize CPAN and PeriPAN to improve patient care within your practice. All right, so the goal number one. All right, so we're just going to be talking about the incidence of mental health disorders in youth and peripartum women. So we all know that there is a high number of mental health conditions within these two populations. We definitely saw a worsening during the pandemic. We all know that some of these reasons are, the stress from those, the social isolation, their financial stressors, um, deaths due to COVID, all the shutdown and everything, all that resulted in worsening of mental health for a lot of people. It also restricted care to a lot of people as, things tried to go virtual or phone call, it really messed with things there in the beginning. And then we're just now kind of getting back to being fully kind of out of that shutdown. But we do know that 1 in 3 teenagers, have an anxiety disorder. Females have a higher percentage than males. Um, it has been the worst developing one. The numbers have increased the most dramatic in that 18 to 25 year range as well. Um, and it's really, the problem with it is that there's either lack of treatment or getting them to get into treatment, and that's really where the ethical perspective is going to come to play as we progress through this presentation. Um, the hard thing is that less than 50% of these people are getting treatment. So that's what we want to focus on. Um, as clinicians, we can easily send a referral off to whatever specialty they need, but it's what's happening in that interim time, and because mental health is underserved in East Texas, that these people can often be on a wait list for a significant amount of time. And what do we do in that interim time? Are they getting worse? Are they staying the same? A lot of people just need something in that in between time. And so we see a lot of ER visits during that time, and sometimes we'll even escalate all the way up to an inpatient psychiatric hospitalization. Um, for worsening depression, anxiety, and poor coping skills. Um, that all these things that we want to start treatment sooner rather than later. Um, we know there's definitely been like a cascading problem, for our youth, as the social family structure has deteriorated over the decades, that leads to dysfunctions in the family, leads to school problems, potential use for drug use, um, lack of structure in the home, lack of accountability. So all these things, have kind of, we're at this kind of point where all these things have compacted together, along with social media use that have made things much worse for certain individuals. Um, you know, like I said, we know that 1 in 3 teenagers have an anxiety disorder, and that's worse for females, and they tend to be the ones more affected by social media than compared to males. So, we want to make sure we're seeing these patterns and knowing, how to screen for them, how to catch them early. But what about perinatal women or postpartum women? We want to make sure that we are catching those individuals' needs as well. And so, perinatal mental health conditions are a leading obstetric complication in the U.S. So, and it is preventable. So, and it's a preventable cause of maternal morbidity and mortality. So, 1 in 5 women suffer from a maternal mental health condition, but the numbers show that less than 15% of moms are actually receiving any professional help. Um, and socioeconomic status plays a big role in that. Uh, Gender, race, and all these things um, are have effects on these different groups. And so those women, that are peri or postnatal, depending on their socioeconomic status, can really make it even harder for them to get treatment. Um, there's data that overdose and suicide are the leading causes of death in women in their first year postpartum. And so, with children now not having a mother or their mother's life being disrupted, it's going to lead to higher incidence of mental health problems in a developing child and youth. So, that's why we got to focus on not just the youth or just the moms, but we need it. That's why Texas is now has both these programs so that we can focus on both of these groups so that nobody's left behind. Kind of that whole, I guess it was a Reagan that nobody's left behind, or I don't even remember now. Um, so just kind of think about those that you've seen in the past and like what difference it could have made if they got treatment sooner, or if they got into treatment. Say you sent a referral for something, but they weren't able to get into it. They didn't have any insurance, or their insurance wasn't accepted, or whatever the barrier was, and think of how if you had something and then like one of these programs, how that could have affected the treatment of that patient. I'm gonna turn it over
So
to,
some
oh, go ahead.
some
Sorry.
considerations and takeaways from this section. So we want our pediatric primary care and obstetric clinicians to know that they can expect that a significant number of their patients have or have experienced mental health distress. That we know that referring out this number of patients means that they're often sitting on a wait list or frankly getting no care at all. And especially in Northeast Texas, we know that the wait for a new patient to see a child and adolescent psychiatrist can sometimes be upwards of a year. So, really a staggering long time for waiting for care. So, if your pediatric patient needs to see a psychiatrist, that we think to ourselves, do they really think that we can wait this long before they can begin treatment? And then we know that for women in Northeast Texas who need the care of a reproductive psychiatrist like myself, they may have very few options in their region. So they may need to travel to a metropolitan area like Dallas or to see a provider virtually, so they have less options. We understand that even if there is no wait list, that a significant number of patients do not attend the mental health appointments they're referred to. And as a clinician, this can be really frustrating because you assess, you send the referral, but either due to a time commitment or stigma or cost associated with mental health treatment for the patient or the family, that they don't follow through with that care. So moving on to our second goal, let's address the outcomes for untreated mental health disorders. So let's start again with our youth population. So we've seen a significant increase in emergency room visits for youth with mental health conditions. With respect to hospitalization, there is a 26% increase of inpatient stays related to mental health conditions from 2009 to 2019, so even before the pandemic. So going back to those ED visits for a moment, you'll recall in December 2021 that the US Surgeon General released his advocacy for protecting youth mental health. And in this advisory, it was reported back in early 2021 that emergency room visits for suspected suicide attempts were 51% higher in adolescent girls and 4% higher than they'd previously been for adolescent boys compared to that same period in early 2019. So thinking back on this time and what our children were experiencing, and even what was going on in our clinics at that time. So even during the pandemic, when someone was suicidal, was having severe emotional dysregulation, they were showing up in emergency rooms around the country. So me working on consults my other days when I'm working on PeriPan, that I saw a lot of people come into the emergency department. A lot of them were kids. So now shifting gears and talking a little bit more about peripartum women, that we know that perinatal mental health conditions are one of the leading obstetric complications in the US and are preventable cause of maternal mortality, like Dr. Blood had said. When mental health disorders are not addressed in perinatal women, we have increased rates of smoking and substance use, increased rates of preterm delivery, which can bring with it low birth weight, an increased rate of NICU admission, and specifically during the postpartum period, we see changes with lactation, bonding, and attachment. And then considering the multi-generational consequences this can lead from untreated maternal mental health conditions, you can see cognitive delays in kids, motor and growth issues, behavioral problems, and of course, the mental distress for those children. So if you're a clinician that's seeing young children, I'd like you to consider the importance of your observation of the mother's mental health. So based on what we just shared, her mental health state directly impacts your patient's development. So physical, behavioral, and mental. So for the kids to thrive, they need a thriving whole family unit to be at their best. We know that also from a cost perspective, the cost of untreated maternal mental health conditions in Texas alone is estimated at $2.2 billion with a B that's spent annually related to untreated maternal mental health conditions. So when you're looking at that time from conception to 5 years postpartum, so just a staggering healthcare cost. And then thinking about depression in perinatal women. So we know that depression itself is an umbrella term that includes both antenatal and postpartum depression. And it may be for patients that have some mild symptoms all the way to meet criteria for major depressive disorder. So it's well known that as many as 1 in 7 women experiences depressive episodes, but many others may not meet full criteria, but still have suffering and functional impairment. There's a study from 2013 that screened 10,000 women who had recently delivered. And again, they found that number 1 in 7 or 14% screened positively for depression. And in 2022, 75% of Texas providers reported seeing pregnant patients who had experienced depression, anxiety, or stress. So this is why it's so important for us to have programs like PeriPan and CPAN to exist. So there are just simply not enough psychiatric clinicians in the state of Texas, and they're not slated to be enough coming soon over the next 5 to 10 years. So to summarize, the outcomes for untreated mental health conditions for youth and perinatal women are devastating, and devastating not just for the patient, but for the family and frankly for the state of Texas. So this is truly a public health crisis, and we must all work together to address it for the good of all of our patients. And it is an ethical imperative that we identify those that are suffering and provide them with the care that helps them achieve the highest level of wellness possible.
Dr. Blood, you're muted.
I always forget to do that. So for goal number 3, let me say what I just said. So we're going to be talking about how these access programs came to be and how ethically important it is to utilize these so that we are helping our patients. All right, so the first access program in the U.S. was developed in Massachusetts back in 2004. MCPAP, I believe, is how they say their acronym. Ours is much better, clearly. We developed and was developed to support clinicians for caring for kids and adolescents. So they had quite a bit of success after a couple years of working out the bugs and getting it out to the providers that in 2012 they rolled out their MCPAP for moms, um, which was the access program for moms. Um, and so, other states have built upon that success. Texas has used their model in building CPAN and PeriPAN. It's moved into U.S. territories, tribal communities, um, even a place, the Federated States of Micronesia, which I didn't even know was a thing. So it is, these access programs are expanding to fill in those gaps where there is no access. All right, so let's talk about these outcomes of collaborative care access models since they've been implanted. So we know that there's a higher percentage of women and children that are having significant mental health problems, and that over 50% of the time they're not able to access care. And if they're in a if they're in a minority or lower socioeconomic status, or even at higher, have a harder time getting into care. And we know there's not enough child psychiatrists, reproductive psychiatrists, um, especially in the more rural regions, like Northeast Texas, that's even worse than in the bigger cities, but still the bigger cities are still don't have enough. And because there's not enough, that's why Texas put so much money forward to develop CPAN and PeriPAN, and modeled it off of previously known access programs that had success. So, and this is a consultative network to enhance the delivery of mental health care across whatever region. So now we have it for children, and then the newly added pre and postnatal women. And so, as providers, you know your families best. You've already built that relationship with them, and so sometimes when you send a referral, it goes into the computer, and you don't really know where it goes. Um, so, with CPAN, you can get to know who you're talking to because we're the same psychiatrists. Uh, we have our set schedule. And so you can get to know us, and then we can help get to know you, and so we can deliver that care better. And so that will then, once they know that you're working with a trusted associate through CPAN or PeriPAN, that further strengthens the relationship between you and your families. So um, first, so when Massachusetts Access Program started, they had two important results. First, that it did allow for PCPs to build a more effective care with their family. Additionally, PCPs were then rated that they had gained more knowledge from those calls, and then that helped not only one patient, but then could help all the subsequent patients that were fairly similar to that. And then secondly, that these consultative calls slowly improve their knowledge, their base knowledge, so that they could over time manage more and more complex cases with confidence. McPap also found that parents were extremely appreciative and actually had a greater trust in their PCP when they knew that the PCP was consulting with a known expert. So these results showed that the access networks like CPAN can improve your knowledge, not just for one patient, but for multiple patients, help you feel more comfortable and confident in your own practice, and then build that better relationship with your patients and patients' families. Now, for women, when you look at these cognitive care models for women, there's multiple articles and managers out there showing that by utilizing a collaborative care model, when you consult an expert, that we can fill in these gaps, and that you extend your ability to help care for these women. We know that if you wanted to be a psychiatrist, you would have gone that route, but we know we all chose, and we all are in our specialty that we want to be in. And so we can help you learn, just like you had to learn how to treat a certain condition. We can help you learn how to treat these conditions, when they're the mild to moderate cases, so that you can feel more comfortable. Sorry, I'm getting spam called. That you can feel more comfortable treating these mild to moderate cases in your own office without needing to click a button and send them off to who knows where and then wait for so long. So we give you all these additional resources and training so that you can be more competent. So let's talk about, these ethical principles. So beneficence, we all went to med school, we all learned that there is an ethical principle in treating patients. So one of them is beneficence, doing good for them. And so if we could just easily get them into, whatever psychiatry or psychology counseling, if we could do it easily, it would be totally fine to put in that referral. But because we have such a shortage, it's not really doing them good just to put a referral in the computer and that be the end of it. So we really want the best interest for these patients. And so utilizing a program that can give you knowledge and skills, give you a sooner consultation, like doing a direct consult, they can be seen in a couple of weeks instead of several months, that gives better care and fulfills this beneficent role. UT Tyler has created a medical school. It's in its second year. It's going to take years and years for that trickle down effect to where we're getting more and more providers in our area. So for now, and I still think it's going to be a growing problem. So I'm not sure it's ever going to fully catch up. So there's always going to be these gaps that's going to be needed to be bridged between primary care and psychiatry. And so you being able to help your patients or having someone that can help in this interim time is really what's going to be important. So, beneficence is building also your capacity, your knowledge, so that you can be a better provider. Then your patients trust you more. They see that you are caring for them more. And this just improves all the outcomes. And because you now have more real-time access to a mental health provider, you're going to improve the care that you're providing for that patient. All right. Non-malfeasance, do no harm. Nobody wants to do harm. We didn't get into this for the money. There's no money really left in medicine anymore. So we did not get in this for the money. So we're in this for treating patients and helping patients. And so the last thing you want to do is harm somebody. So there are instances of when harm is happening when people are going untreated. So we know if we can get the sooner care, the better outcomes. I think day one on my ER rotation in med school is, in the ER, they're talking about, getting care started as soon as possible in the ER. That's so true for psychiatry as well. The sooner, the better. So if we can treat kids, we're going to prevent a lot of adult mental health cases. For treating the mother, so that she can provide the best care and nurturing environment for her child to be brought up in, be improved outcomes for both the mother and the child. And so, just like you wouldn't let a wheezy asthmatic kid go, several months before they can get an inhaler or whatever treatment they need from a pulmonologist, you would want to intervene sooner. Same for mental health. Lastly, we'll talk about justice. So justice is generally interpreted as fair, equitable, and appropriate treatment for all of our patients. All patients and for all of their healthcare needs. So I know you can treat their fever really quickly. You can give them antibiotics. It's a 5-10 day course, right? We wish anxiety, depression can be treated equally. It's not going to be treated as quickly, but we can get them access to treatment at a much sooner rate or a sooner time frame. So, because things we do know that they are progressive diseases without treatment. And so getting them their depression diagnosed, getting their anxiety diagnosed, or ADHD, all those things can be done, in your office with the help of CPAN or PeriPan, and so that you can start the treatment sooner. We help you, learn what assessments to use, what validated screening tools to use, so that you can determine, what condition is best for them. And so once you do an assessment, then, you move on to treatment. So if we can help you learn how to assess better and you can catch more conditions, then you're going to be able to treat more. And so using the right tool for the right job is important. And so knowing what to do. So that's why we have all these CMEs on these different topics. So you know what's the best way to assess and then treat all these various conditions. So care being provided at the right level and at the right time, avoiding those long wait lists for youth and women that are mild to moderate, saving the more complex ones to go being actually maybe seen by the psychiatrist sooner, then, we can help the whole community. All right, so what did Texas do? We've already talked about how these access programs got started, but what did Texas do? Texas knew that there was a crisis and it was urgent to get these mental health not just treated, but to make sure that there was enough treatment for all of Texas. Texas is so big and broad and such a diverse population that the 2019, the 86 legislative body, that's when they put forth the bill and it passed so that we can have the Texas Mental Health Care Consortium, which led to the CPAN network, PeriPan, and all that. What it provides is the real-time, peer-to-peer telemedicine-based consultation services. We can help coordinate care. We can give training. CPAN assists pediatricians and family practice providers, as well as nurse practitioners, physicians assistants, anyone who's treating in the primary care setting for patients under 23. And then in 2020, Texas came out, Texas Maternal Morbidity and Morbidity Review Committee released its recommendations, which included that they needed to improve their access to mental health and substance abuse care for women from preconception through postpartum period. And so in 2021, the funds became available through the Texas Legislative, and that's when the Perinatal Psychiatry Access Program, network, began. And so, we now have this. Our region has Dr. Robinson and access to other reproductive psychiatrists so that any obstetric, either pre or post partum you can call them and get help for those patients as well. Because maybe the OB/GYN will see them, 6 weeks, is the typical, but what about after 6 weeks? Then either the mom is bringing the infant and you may notice it in the mom, or the mom's just coming for routine care, their annuals or whatever they're coming in for in their primary care setting. So having access programs is important to Texas. I already mentioned that Texas is large and consists of both densely populated areas and then very urban and then very rural areas. So to make sure that all 254 counties, receive the same care, divided it up into these 12 regions or health-related institutions. So we got for the Northeast region, we have UT Tyler, and to our west, we have UT Southwestern. To our south, we have UT Houston and Baylor Houston. So every county is covered. So and that's now both CPAN and PeriPAN. Dr. Laura Williams is the medical director of the CPAN, and she's down in the Baylor College of Medicine in Houston, and she's been a great advocate to the state to really know what are the needs and how to tweak the programs and what they need from the legislative body and the government so that we can do our job the best we can. And we have Dr. Sarah Wakefield. She's the medical director for PeriPAN. She's out in Lubbock at Texas Tech Health Center. I said both of these ladies are wonderful, and they've working with the politicians to make sure that we continue to receive the funding to help Texas. All right, so this is kind of a breakdown. These are the regions. And then to the right, you can see on the graph, those are the numbers you need to call to get to your designated area. So for Tyler, it's 1 and 3. If you're in the UT Southwestern catchment, which is that dark blue or purple, I can't really tell, 1 and 2. So this is how you know how to get to your region when you call the number. And if you don't know, you can always just call the main and they'll help you get to the right one. It's not a big deal.
Okay, so the goal of our Access program is to provide a network of support for both youth and perinatal mental health. So to meet that goal, we set forth to support providers of pediatric and maternal health care to identify and manage their patients' mental health and substance use concerns in real time and in an environment in which reproductive psychiatry resources are scarce. We want to expand access to education about pediatric and maternal mental health disease burden and effective treatments. And we want to improve the mental health care and systems of care for children and adolescents and women who are pregnant, postpartum, suffering perinatal loss, or planning pregnancy. So we needed to improve the mental health care and systems of care for children and adolescents of Texas by supporting women who care for them by leveraging collaborative care models. So by doing so, we would improve overall equity and access to care for those groups that need improved mental health. So our core components of our access projects for CPAN and PeriPAN, these multiple core components are used to ensure the greatest level of support for Texas clinicians caring for children, adolescents, and perinatal women with mental health needs. So these components include that we want it to be prompt, real-time, phone-based consultation by experts in the mental health field. And our team is available live Monday through Friday, 8 to 5. So when you're in clinic, we're there to help support you. So no need to send a message through an EMR and wait days for a response or more questions. So get the answers you need right away. Our consultation line is quick and easy as walking down the hall to speak to a colleague, just like any other curbside. And after hours, you can leave a message on our secure phone line and it'll be returned the next morning or at the time of your choosing. Our clinical guidance is helpful for assessment and treatment, including medication management is available from our mental health experts. And our experts are here to address any issues related to mental health, including substance misuse issues. Our phone lines are manned by mental health professionals and have psychiatry experts standing by to talk with clinicians. And these psychiatry experts include both child and adolescent psychiatrists and reproductive psychiatrists. Counselors are also available to assist clinicians in determining the appropriate therapy type for their patients, which leads us to our next core component. So resource navigation and vetted referral sources. So it's a known challenge for us in Northeast Texas to locate mental health services for our patients. So issues such as which insurance carrier the patient has, or location of the provider, or even locating the most appropriate type of mental health care can be extremely time consuming and can be a barrier to care. For example, it can often take hours or even sometimes days to locate the right counselor for a patient. So one quick call to our CPAN or PeriPAN service, and we can help do that legwork for you. So you can help leverage us. And our team of mental health professionals here in Tyler has developed a database of over 300 mental health care resources to draw upon. So that ensures the right fit for your patient's need, insurance status, and location. So we don't just send you a list. The team actually calls to vet these referrals and resource providers sent to you to make sure that they're available, they accept your patient's insurance, and are skilled in the area of need for your patient. So just as each of your patients has individual needs, each list of vetted resources provided by your CPAN or PeriPAN team is also individualized for the specific patient at that time. So some examples of these resources and referrals provided include individualized and family counseling, psychological testing, drug and alcohol treatment centers, and autism testing. And counseling examples include grief, depression, anxiety, phobias, and maternal loss. So it's hyper-focused for what people need. Sometimes these resources also include support groups. So for example, we've had calls where there's been a fetal demise. And not only did we provide options for specialized maternal counseling, but also options for support groups for the patient and the family. So we have to remember that when one person in the family is struggling with mental health issues, the whole family is impacted. So we with CPAN and PeriPAN can assist in finding support for the family of your patient. So another core component is training and educational opportunities with CPAN and PeriPAN. So each consultation with a psychiatrist is a one-to-one education with a psychiatry expert. And additionally, we have continuing education made available multiple times each month from hubs around the state through webinars and Project Echo. So we have educational topics that are varied and address mental health care for youth and women who care for them. And finally, all services provided through CPAN and PeriPAN are state funded and free for you to use. So not only that, if free wasn't enough, that for the time that you as a clinician are consulting with psychiatrists, that is billable for either time or complexity-based billing. So there's not the opportunity cost in terms of the time you would be otherwise spending. So as I mentioned on the previous slide, continuing medical education is a core aspect of CPAN and PeriPAN and something that we're all really passionate about. You'll see on this slide that there are 3 examples of the types of CME sessions that are being held by our different hubs. So we have webinars that are offered for both child and adolescent psychiatry as well as perinatal mental health. So that's a project I've been really excited to be involved in. They're offered virtually for clinicians at several times throughout the month, with some sessions providing NCPD credits for nurses as well. And all continuing education is no cost for those providers that are enrolled in CPAN and PeriPAN. So great reason to join us. So the dates, times of webinars for CPAN vary based on the hub that's sponsoring the session. And then for PeriPAN webinars, they're held on the 3rd Tuesday of each month from 12 to 1 and are hosted by the Texas Tech Health Science Center at Lubbock. Our Project Echo is made available to you through the Texas Child Mental Health Care Consortium at no cost. And CPAN Project Echo is scheduled as a series of 6 sessions that's held every spring and fall. And the fall 2024 schedule is going to be released shortly. So check that out. And at the bottom of the slide, you'll see that there's a list of links where you can find our CPAN and PeriPAN webinars for the rest of the year. And sessions for 2025 are currently in discussion and are going to be released a little bit later this year. So if you're interested in a specific topic that you'd like addressed either for CPAN or PeriPAN, just let us know, because we're always wanting this to be as high yield as possible for our community clinicians. So next, this slide shows that the remainder of the CPAN sessions available to you through the UT Tyler Health System Hub, as well as sessions marked as TPS PeriPan Echo. So these Project Echo sessions are facilitated through Texas Tech Healthcare Lubbock and are in collaboration with the Texas Pediatric Society and are supported by a grant from Blue Cross Blue Shield of Texas. So you can register for these series by snapping the QR code that you see on the screen. And if you have any trouble accessing the registration, just contact us here at the university and we're happy to assist you. As I mentioned on the previous slide, we are in the process of planning our 2025 CME schedule. So we'll be partnering again with UTMB Galveston and expect to be able to have our schedule finalized by October 1st. So check back with us. So next, that as I mentioned in our core components, that we provide prompt phone-based consultation that is essential to our access projects. And it's through this consultation that you'll receive clinical guidance and assessment and treatment for presenting mental health symptoms, as well as resource navigation and vetted referral source for your patients with complex mental health needs or substance use issues. So our services are provider to provider. We never want to interfere with the relationship that you have with your patient. And this support that we provide to you many times is available for different types of clinicians. So pediatricians, pediatric nurse practitioners, family practice clinicians, either physicians, family nurse practitioners, and physician assistants, OB-GYNs, nurse midwives, women's nurse practitioners, and we even support psychiatrists and psychiatric mental health nurse practitioners and psychologists too. So although these consultations with the psychiatrist are provider to provider, you can have your support staff contact us on your behalf to schedule the consultation call with a psychiatrist or therapist just to facilitate things. And if you'd like a call back ASAP, that call will be returned to your cell phone in under 30 minutes. And the statewide average time for a return call is less than 10 minutes. And last month, our hub's return call time was under 4 minutes. So this is really quick. So if you'd like to schedule the call for a later time in the day or during business hours, that's fine too. And we even have providers call one day and ask for a call back on another day at a specific time that's convenient for them. So we can really schedule this around your clinic's needs. So our desire is to make our consultation process as quick and convenient for you as possible. So we want to support you as a provider is unlimited and no call is too small. So if you're not sure if we can help, just give us a call anyway and we'd be happy to talk it through. And you might be surprised how often we can support you and your needs. So for our Texas Access projects, our goals are to fill gaps that we know that to access mental health care experts is limited. And there just aren't enough psychiatrists to treat all patients with mental health needs. CPAN and PeriPan is able to help fill those gaps by being available for primary care and women's health providers as real-time consultants. And a quick phone call and clinicians are able to access the information necessary for their patients' mental health needs. So we also help to build capacity. So having mild to moderate mental health needs addressed within the primary care setting for patients who have severe mental health care needs are able to see mental health care experts more timely. So you really facilitate the whole system through this model of care. And our access programs are also here to help improve outcomes. So that real-time access to experts in mental health, you can support both your patients' mental health needs. They can be treated sooner with the appropriate type of therapy, medication, or both, and really fitting your patient's individualized needs. And we can also reduce stigma. So when mental health is addressed in the primary care setting, the same as physical health, the patients learn that mental health care is just an overall part of their wellness. So that's one step to normalizing mental health care. All right, so we'll move on to goal 5, identifying barriers to mental health assessment and treatment in your clinical setting. So this is one of my favorites. So listed here, we have several barriers that we've heard from clinicians related to improving mental health outcomes. So I like to kind of have people think about how many of these apply to you or your clinical setting, and there might be multiple. So the first one is limited experience in assessing for mental health disorders. Second, limited experience in the treatment of those mental health disorders. And next, your clinic doesn't support you in providing mental health care treatment. And finally, your clinic setting doesn't routinely screen for mental health disorders. And I would like to add a fifth one of just being overwhelmed in terms of you're busy, not having enough time to already do a lot of different things, part of your clinical day. So all of these are legitimate barriers, and we know that these exist for many people. So we at Texas CPAN and PeriPan would like to do for you is to assist you in trying to remove these barriers, and these are surmountable barriers. So when speaking for the limited experience of assessing and treating mental health disorders, our psychiatrists are university faculty and have the expertise not only to assist you through your cases through one-to-one consultation, but also to impart knowledge to you at the same time that you learn from experts in the field. And if your barrier is practice-based, we'd like to assist you with this also. So our CPAN and PeriPan psychiatrists are available to speak with your clinic medical leadership to talk about how we can support you in your clinic in providing mental health care and discuss the importance of routine mental health screening in the primary care and obstetric setting and how this can be implemented into your clinic's workflow. So we know there are barriers to quality mental health care for children, adolescents, and perinatal women. And your CPAN and PeriPan teams across Texas are here to support you and want to support you and your patients.
All right, so how can CPAN, PeriPan help develop a plan to utilize utilization to improve patient care within your own practice? All right, so the initial step is to just get enrolled. So getting enrolled, get you access to all this. You can enroll by phone. You can contact um, the phone number directly, and they will get you enrolled. If you're already enrolled, just start using it. So the question is like, when do you use it? Like, how do you utilize the service? So you can utilize it if you like pre-chart and you know someone's coming in that has this thing that you're going to need help with. You can call them and kind of have a plan going into it. If they screen positive for a certain depression or anxiety or whatever, um, you can call us before you see the patient. You can call us while you're seeing the patient, say, hey, I want to step out. Let me consult uh, um, the doctor, consult the child psychiatrist real quick, or the reproductive psychiatrist real quick, so that you can step out, have a consult, and then you can come back in with a plan ready to give to the patient. Just like if you had to go out for test results, you done like a rapid strep or whatever, and then you got to check on that, and then you come back in with a plan for treatment. So, or you've already talked to family, you had an idea, but clinic was so busy, you couldn't talk to us now. You can call afterwards. You can text to set up a time. Really kind of we're at your whenever you need us, we're gonna be there, so you can have your nurse or MA or whoever call to get the call set up. The actual consult's got to be doc to doc, but just getting it set up, the nurse or MA can provide all the information, and you just have to get on the phone and have that quick discussion with us, and then you're done. You can set them up. You can do it as needed, either way. Like I said, no call is too small, and the services are unlimited for everyone. So that's, but sometimes, the psychiatrist may not have enough information, or you'd be like, I'm really not sure about this. I'm not sure about that. And that's when we can do a direct consult, and we can see them that one time, do a full consult, and give you our assessment and recommendations. We can help, what kind of screening tools you need. Like everyone's, a lot of EMRs have embedded PHQ-9s or GAD-7, but sometimes they need something a little bit more than that, so we can help what screenings to use and what a screening means, what is a positive, does this really mean something, so anytime you have a question or concern, you can do that. Um, see, so all we need is, the patient's information. And, if you want, we'll get like y'all's MRN number for them, their date of birth, and that's so we can track it. So if you ever call again on them, we'll have access to the previous information, and we can go back and see what we talked about last time, because sometimes of course, there's more than one of us, And so if you talk to a different doctor, and then it's like, I'm on today and you call, I can go back and look at the note that the previous doctor made to see what was discussed and what the plan was. So our children deserve it, moms deserve it, you deserve the access to it, and we can do this together. Oh, I think the slides are going backwards, Laura. Couple more. Did that one. Did that one. There we go. So here's some quotes that we have from providers that have used it. CPAN is a great asset to me. The intake coordinators are extremely knowledgeable and help me in providing the best care for my patient. The child analyst and psychiatrists are helpful in advising medication, therapy, and other treatment modalities or evaluations needed. Having limited resources here in East Texas makes CPAN a necessary part of my treatment strategy for kids. Mental health services are in desperate need. The PeriPAN program allows me to take excellent care of my pregnant and recently delivered patients. I know I will get good advice with a fast phone call, and I don't have to wait and hope that a patient calls in their insurance and finds a provider that is accepting new patients in a timely manner. So these are quotes from actual providers. So these are the references from today's slides. And then we will open it up for any questions that you have today.
So this is Dr. Youngblood. I am a family practice physician at UT in Pittsburgh. And I just want to say that I've used this program numerous times and have always been excited about the responses that I've gotten. I've waited a couple of minutes for a phone call during a busy practice, or I have had them call me back after I've finished or called me the next day. I've even had some patients where I didn't have the answers that the psychiatrist were discussing with me. And so I had my nurse call them and we were able to help to facilitate maybe some medication changes or getting them set up for therapy. I even had one last week where I just needed some assistance with trying to find some self-help books for a teenager. And they were very helpful in that sense. And I think it's a great opportunity that we have here. And I stress it to our residents that we train to really to utilize this in their treatment of kids. And I just want to thank you guys for all the hard work that you do.
Thank you, Dr. Youngblood. We appreciate the kudos and the team. I'm actually going to have the team, if they're able to show their faces here on the camera so that people can see when they call who they're talking with. We have Caitlin and Michael and Nicole, and we do have Elizabeth, but she's on maternity leave right now. So when you're calling or you're texting, if you're texting Michael. And then when you're calling, it'll either be Nicole or Caitlin who answers the phone. I'm the B team, so if somebody's at lunch and you call and they're not available, I may be the person answering the phone for you. I would like to open up. We're getting close to the top of the hour. We'll stay as long as you would like. But is there anybody on here who would like to bring forward a case or share an experience that they may have had with CPAN that they can share with others? You have two psychiatrists right here waiting to answer questions for you. So it can even be a general question about medication management, or it could be something more specific. So, we don't have anybody that's coming forward right now, but I do have a question. Dr. Robinson, we do not have reproductive psychiatrists in our region. So, when do you see providers leveraging the service of a reproductive psychiatrist most often? What are you hearing from folks?
So one of the things that's been really fantastic for me working with Texas PeriPan was I'd actually worked in Massachusetts during fellowship. And so seeing MCPAP for moms in real time and seeing how people were leveraging it well into their clinic was really, inspiring, and kind of what led me to want to work with Texas PeriPan. And so I'm seeing a lot of times when either people are having an idea of what they want to do and are calling us to kind of double check in terms of, say, someone is struggling with depression and they're already on, say, sertraline 25, and they're wanting to run by if it's not working after X number of weeks, what do they do next? Should they go up on the dose? Should they switch? So a lot of times, as Dr. Blood was mentioning, so either people are wanting to talk about what happens when people aren't improving. So if someone had pre-existing mental health problems, you're seeing them for a follow-up, they're not getting better. What do you do next? And really kind of talking that through. And if needed and wanted, if we see them for a direct consult for one time, we can see them too. And I think that that provides that extra layer of assurance of, we are seeing what you see, we're all on the same page. And that really, I think, helps build confidence. And I've really loved seeing also just coming up with multimodal plans. So there's the med management, there's the referrals to other therapy resources that may really help people thrive, since we know that usually a combination approach, especially for more moderate to severe symptoms, can really be effective. So just partnering with all our local clinicians has been fantastic in terms of supporting people along the way, educating, and really kind of upping people's game in terms of what they're doing in real time the next time someone that comes in with a similar problem comes back.
Great. Thank you very much, Dr. Robinson. Any comments from within the attendees? Dr. Castle, thank you very much for your comment that you've utilized this a lot and really appreciate us. Well, we appreciate the care that you're giving your patients for sure. Dr. Blood, when we think about how to create a workflow that includes CPAN and PeriPan, we know that providers are strapped for time. How long does it typically take for a consult, would you say? Because I think that maybe if somebody hasn't used our services, they may not be familiar with how much time it takes.
Yeah, so if the time that I'm on the phone with the provider is usually anywhere from 5 to 10 minutes. Sometimes it's a little less, depending on what the question is, the complexity of the question. So if you're really strapped for time, the most ideal thing would probably be to do is have your MA or nurse call to give all the demographic information and the chief complaint, so that we're set to talk just about the patient, and you as the provider doesn't have to give all that information, because I'm slow at inputting data into this system. And so when I have to collect the demographic information, that probably takes just as much time as it does to actually talk about the case. So ideally, if you want to spend less time talking to me, then get your staff to call ahead with that demographic information. We can call right after, or you can set up a time so that we can spend, as little or as much time on that phone call as you have.
Thank you very much. One of the things that we do here in Northeast Texas, and I've kind of dubbed it the name Psychiatry Roundtable, and Dr. Blood and I did this last week down in Nacogdoches, is we can come to your clinic and sit down with your group of providers and do a psych roundtable. Fire questions at Dr. Blood. Let's see if he can stay on his toes the whole time. And we can consult on cases that are specific, or even questions that are general. Which medication is best to start first in such situation? Or I've heard this about black box warnings, and I'm uncomfortable treating with stimulants. What do we do if I'm not permitted to prescribe a stimulant? For example, nurse practitioners have that kind of a burden. They are not permitted to script that. If you would like to have us come and do a roundtable at your clinic, we would love to be able to provide that service to you. Again, that's at no cost. And then we also have Dr. Metter, who is on our team as well. She is in clinic today. Dr. Blood or Dr. Metter and I can join you at your clinic. We are after hours. Folks are still in here, and I appreciate that. Do you have any other questions, or if you have been using our services and you have any thoughts on how we can continue to provide more support for you, or you have questions on direct consultations where we can provide that one-time full psych consult for your patient, we're here for you to chat about that. All right, I think we have a quiet group. I have on the screen the QR code for you as a provider. If this is the first time that you are visiting with us today and being part of our continuing education session, please note that there is a comment that says the first time texting your attendance, you'll need to send an email to our CME department. The phone number, that 855 number, please make sure you do that. If you have any problems getting your credits, contact us here at cpaninfo@uttyler.edu. That is cpaninfo@uttyler.edu, and I'll get you hooked up with our CME department. Dr. Robinson, Dr. Blood, thank you so much for facilitating our session today. I appreciate your time very much. And for those of you who have used our services, thank you. We look forward to continuing to serve you. And if you have not used our services, please try us out. I think you'll be pleasantly surprised at the service that you receive from this Northeast Texas team who's dedicated to the mental health of children and their mamas and families. And you all have a fantastic day. Thank you.